The next of the normocytic anemias are those with predominantly intravascular hemolysis, and the first of them that we want to cover is paroxysmal nocturnal hemoglobinuria. I actually prefer to explain this in my own words, and then I'll walk you through the slides, so let's just take a blank screen for a second and remind ourselves of a couple points. First of all, the red blood cells, they live in a very dangerous environment. They live right next to complement. Their neighbors are deadly. And so the red blood cell needs to be protected against complement. And in fact, this doesn't apply to the red blood cell only. It also applies to the platelets and the white cells as well. And so the red blood cells, in order to protect themselves against being destroyed by their neighbor, i.e. complement, they actually have a molecule on their surface, and that molecule on their surface is called DAF, decay accelerating factor. They also have another molecule on their surface, which is called MERL, membrane inhibitor of reactive lysis. And so these two molecules, what they do is, were complement to get activated, if complement were to try to come anywhere near the red blood cell, these two molecules would inactivate the complement. DAF stands for decay accelerating factor, and it accelerates the decay of C3 convertase, for example. Now, it's important to then note that DAF and MERL are both connected to the red blood cell membrane by an anchoring protein called GPI. So this is GPI. And this anchoring protein is essential because it's what allows DAF and MERL to be expressed on the surface of the red blood cell. In paroxysmal nocturnal hemoglobinuria, the problem is the patients get an acquired. Note that it's an acquired. It's not inherited. It occurs later in life. It's an acquired defect in the myeloid stem cell, and because there is a defect in the myeloid stem cell, GPI will not be present in all cells derived from the myeloid lineage. So, for example, the platelets will not have GPI, the red blood cells will not have GPI, and the white blood cells, in particular the granulocytes, will not have GPI. And because there is no GPI, there's going to be no DAF. And if there is no DAF, and there is no MERL, for example, then the cells will be susceptible to destruction by complement. And that's the problem in paroxysmal nocturnal hemoglobinuria, and that is that the cells are susceptible to complement destruction. Now, we're not done there. We've got to go one more step further and explain the name, paroxysmal nocturnal hemoglobinuria. In order to understand this, you have to go back and remind yourselves from physiology, when we sleep at night, we actually breathe shallow. And when our breathing becomes shallow, we retain carbon dioxide. And when we retain carbon dioxide, that then gives us a respiratory acidosis. Now, acidosis has the ability to activate complement. So at night, we are activating a little bit of complement. Of course, patients who have normal red blood cells and normal white blood cells and normal platelets would have no problem with this activation. They could simply protect themselves against that activation. However, in patients who have an absent GPI and don't have these protective molecules, they will be susceptible to complement-mediated damage in particular, or classically when they're sleeping at night. And so that's why it's called paroxysmal nocturnal hemoglobinuria, because on some nights, i.e. paroxysmal, when the patients are sleeping, they actually get lysis of their red cells and platelets and granulocytes, but in particular their red cells, which then results in the hemoglobinuria. When they wake up in the morning, they've got very dark urine. So that's the summary. Now let me walk you through what the text says. Paroxysmal nocturnal hemoglobinuria is an acquired defect, that's important, in the myeloid stem cell, that's important, results in absent GPI. This then renders the cells susceptible to complement because there is no DAF and there is no MERL present on their cell surface. In particular, the patients get intravascular hemolysis that occurs at night. Intravascular because the complement destroys the red blood cell within the blood vessel. At night because that's when complement gets activated. Why does it get activated at night? Because there's shallow breathing resulting in a respiratory acidosis, which then results in activation of complement. And of course, the red blood cells, the granulocytes, and the platelets are all lysed because each of these cells are lacking the GPI linker molecule. This presents with intravascular hemolysis, so the patients present with hemoglobinemia. If you were to look in their blood, you would see hemoglobin. Some of that hemoglobin will leak out into the urine, giving you hemoglobinuria. And also, some of the hemoglobin in the urine will be taken up by the tubular cells in the kidney, and as it piles up in the tubular cells of the kidney, it'll pile up as hemosiderin. Now eventually the tubular cells of the kidney will be sloughed off as they turn over, and that'll give us hemosidenuria, but that will be seen days after the hemolysis, so it won't be seen with the acute episode, but it might be useful if you're suspecting hemolysis and you want to check for it days after the event occurred. One way by which we can screen for this disease is to introduce sucrose into the patient's serum. When we introduce sucrose, that activates complement, and that could then destroy the red blood cells in a screening test. A confirmatory test would be to acidify the serum. If you acidify the serum, you would activate complement, which would then also confirm the disease. Nowadays, the more recent test, and the test that's more often used in laboratories today, is to look for a lack of CD55 on the surface of the red blood cells. If you have red blood cells and you want to see whether they have CD55, an important thing about CD55 is that it uses GPI as a linker molecule. So if there is a population of red cells in the patient that lacks CD55, that would be a way by which you could prove that the patient has paroxysmal nocturnal hemoglobinuria. And CD55 really is DAF, so that makes sense because DAF was the whole molecule that we started this discussion with. The main cause of death in patients is thrombosis. The idea here is that the complement's going to destroy the red cells, the platelets, and the granulocytes. And so when it destroys the platelets, the fragments of the destroyed platelets can actually go into the circulation, and that can activate the coagulation cascade, resulting in thrombosis. And so that's the main cause of death. And so examiners love to go after it because it really tests you on two principles. One, you need to remember that the platelets are also lacking GPI. And two, that's the major cause of death in these patients, thrombosis of hepatic vein or portal vein or cerebral veins, for example. Complications of the disease include iron deficiency anemia. Why would they get iron deficiency anemia? The answer is these patients are losing iron in their urine. As they're losing hemoglobin, they're actually losing iron. And so they can develop an iron deficiency anemia. In addition, 10% of the patients can develop AML. Now remember that I told you that this disease is a mutation in the myeloid stem cell. So imagine if there's one mutation in the myeloid stem cell, it's not going to be hard to develop another mutation in that cell, and eventually that could result in AML. And 10% of the patients do develop AML, and that is a high yield association as well.